My name is Kaela Parnell. I recently completed general surgery residency at UT Southwestern and Parkland Hospital in Dallas, Texas. Thank you for having me here today. I will be discussing our experience with telemedicine on an acute care surgery service. We specifically looked at improving clinic efficiency and patient access to care. I have nothing to disclose. This started off as a quality improvement project in which we established a virtual post-op clinic on an acute care surgery service. The main goals were to improve our outpatient clinic efficiency and patients' access to care. This took place at Parkland Memorial Hospital in Dallas, Texas, which is a large urban county safety net hospital and a level 1 trauma center. The patients that we serve are of the lowest socioeconomic class with a large number of indigent patients. The problems we were experiencing in our outpatient clinic was that it was congested with short post-op visits. The majority of our clinic was made up of post-op visits. The patients spent a lot of time in the waiting room and a short amount of time with the provider. The patients themselves have a large socioeconomic hardship to even make it to clinic. They often could not afford transportation costs, the cost of parking, childcare, or time off work. So them spending this time and money to come to clinic was a significant burden. There was a low number of new patients seen in this clinic and a low number of outpatient operations scheduled from this clinic. So we decided to establish a virtual post-op clinic to help offload our providers during this time, increase the number of new patients that we could see, and help our patients who cannot make it to clinic due to socioeconomic burdens. We retrospectively reviewed the patient and clinic outcomes before and after establishing this virtual post-op clinic. The patients included in this project were specifically laparoscopic cholecystectomy patients. These are patients who came through the ED, underwent an urgent or emergent laparoscopic cholecystectomy. They had an uncomplicated post-op course and were discharged home within 24 hours. These are the patients that we enrolled in our virtual post-op clinic. When we discharged them, we provided them clinic phone numbers in case they had questions, and we gave them ED warnings. The virtual post-op clinic took place on post-op day 14. It was a telephone call in which we asked them this standardized list of questions to evaluate their clinical status. We also reviewed their pathology and again provided ED warnings and phone numbers. If we could not get in touch with them during the first phone call, we would attempt to reach them a second time. If we could not reach them a second time, we would then schedule them for clinic and send them a letter in the mail telling them about their clinic appointment. The data that was collected before and after the virtual post-op clinic was mainly looking at the clinic composition, the new and post-op patients before and after, the number of operations that we scheduled, and to ensure patient safety, we looked at the number of ED visits in this group of patients, as well as the loss of follow-up rates. The virtual post-op clinic was established in 2018. We compared the data before in 2017 to after in 2019. So if we look at the before column, we specifically looked at data in an 8-week period between February and March. There were 800 patients scheduled to be seen in clinic in 2017. This is compared to the after group, which again was an 8-week period, February to March in 2019, in which 818 patients were scheduled to be seen in clinic. There was a significant increase in the number of new patients that were scheduled, from 17% to 31%, and there was a significant decrease in number of post-op patients scheduled, from 50% to 27%. These were all statistically significant. The follow-up group of patients were just those patients with wound care or other issues that required clinic follow-up, but not necessarily new or post-op patients. We also saw an increasing trend of operations scheduled from 8.4 to 11.5 operations scheduled per 100 patient visits. However, this was not statistically significant. This is just a breakdown of the number of surgeries performed before and after the virtual post-op clinic was established. So in 2017, during that 8-week period, 184 laparoscopic cholecystectomies were performed. This is compared to 199 in 2019. These specific patients were retrospectively looked at for the ED visits that took place after their surgery. We looked at a 3-month period following their laparoscopic cholecystectomy, and 21% of patients in both groups went to the ED during that 3-month period. So there was no statistical difference between those patients. Of note, the patients who went to the ED, they went within 1 week after their surgery. So before the virtual clinic visit was scheduled or their post-op clinic was scheduled. This is a breakdown of the virtual clinic looking at the loss of follow-up rates. We are comparing the virtual clinic in 2019 versus the post-op clinic in 2019, again, an 8-week period. There were 287 patients scheduled to be called in our virtual clinic versus 223 to be seen in the post-op clinic. There was no no difference in the loss of follow-up rates between the two, 34% versus 38%. Of the 66% of patients that we did reach in our virtual clinic, 11.6% crossed over to a clinic visit because we were clinically concerned about their status or they had concerning pathology. The patients enrolled in this virtual post-op clinic were part of our Parkland Fast Track program, in which they were seen and evaluated in the ED, started on IV fluids, IV antibiotics, they were made NPO, and then they were transported to the OR, underwent a laparoscopic cholecystectomy. They were covered in the PACU, and when deemed medically fit for discharge, they were discharged home and never had a hospital admission. The conclusions of this project were that the virtual post-op clinic at our institution did improve clinic efficiency. There was an increased number of new patients and decreased number of post-op patients seen in our clinic. There was a slight increase in operations scheduled, although not statistically significant, and it did not compromise patient safety. There were no changes in ED visits or loss to follow-up rates. The challenges with this project was just effectively communicating and educating our patients, the rotating residents, nursing staff, ED staff about this virtual clinic so that people were not referred to our normal clinic. The majority of our patients are not English speaking, so there's always a language barrier, which did not change. The sustainability of this project was somewhat of an issue in that this still required a large number of providers to call all these patients and make these virtual visits happen. In the future, we would like to expand this to appendectomy and hernia patients. We would like patients to upload the pictures in their chart. We would like to call patients before they come to the ED and also incorporate satisfaction ratings. I would like to acknowledge Drs. Luke, Oltman, and Scott for being great mentors during this project, along with everybody involved in this project. Thank you very much for having me. I appreciate it.